Can everyone see slides there?
It's thinking, yeah, but we see the like the next slide too.
Oh, you see that thing. All right, hold on. You can all have a preview. Sorry. Give me one sec to get it pulled up.
While Todd's doing that, I'll also, I'm going to probably unnecessarily, but reintroduce Manang Shah, who is an associate professor in the Division of ID here, whose work is focused on TB and HIV, but is also, among many things, a modeler and has worked with Todd on this paper. And it's also, the creator and I don't know what we're calling it now, Manang, but of the creator of HIV Assist, which I think is a tool many of us are familiar with. Okay, great.
Okay, now my slides are there.
Looks perfect.
Oh, fantastic. Okay, thank you. And thanks for everyone's patience. I really appreciate the opportunity to be here to talk to everyone. So this is my plan for today. Briefly go over the Ending the Epidemic initiative, which is sort of the motivation for this work, talk about the way the model works and the way we fit it, and then go over results. And then I also thought I'd maybe take some time to go over some preliminary work we're doing, which has not been published on projections for what COVID-19 might do to HIV transmission. There's a lot of math in this model, and I really like that, but I recognize that not everyone shares that characteristic. So I will try and keep it light on the math, and here just give you enough that enough of the details that you can see we've done our homework, right, and to give you a sense of why you can trust the projections that we make. So with that said, as we all know, the Ending the HIV Epidemic set out to reduce incidence by 75% over 5 years and by 90% by 2030 over 10 years. And the initiative focused on these 50 high burden counties in 7 states with a high rural burden of HIV. There's Baltimore there. And when they announced the initiative, they said, we think we can do this with sort of existing strategies that we have, in particular, diagnosing people rapidly, treating people who have HIV to get them virally suppressed so they can't transmit, preventing new infections with measures like PrEP, and then responding to outbreaks. And I remember hearing the early presentations on this, and it occurred to me that these first 3 pillars really present a very testable hypothesis for a model, right? And so specifically, the question that we set out to answer with a modeling study is, to what extent do you need to do these things in order to achieve your stated goal of a 90% reduction? And we want to answer that question not broadly for the nation, but for specific local epidemics, right? So how frequently do you need to test for HIV? What proportion of people who have HIV do you need to get virally suppressed? What proportion of people at risk need to be on PrEP in order to achieve reductions at the scale that you're talking about, right? And just a word here, when we represent PrEP in the model, we represent it as both Truvada, right, a pill that reduces your risk of getting HIV, but also regular follow-up, so testing every 3 to 6 months. So when we ask these questions, our primary outcome here is going to be the reduction in the number of incident cases from 2020 to 2030 relative to the 2020 level, right? So that's what they're framing it as a % reduction in incidence. The model that we use is a compartmental model, right? And from a high view, what a compartmental model does is it chunks up the population into different compartments, right, or subgroups of the population. And we say that within each compartment, people behave the same, right? So transmissions rates are the same within compartments, rates of suppression are the same within compartments. And what this really means is that we're representing the average behavior of people in each compartment. And then once we can describe the rates at which people move between these, we can make projections for the future, right? So the way our model is structured is we have one compartment for people who are HIV negative, and there's a proportion attached to that compartment that says how many people are enrolled in a PrEP program. As people become infected with HIV, They moved to undiagnosed acute HIV states, and acute HIV for our model is the first 3 months or so when viral loads are high and risk of transmission is higher, right? And notably, some people can still be in a PrEP program, be HIV infected, but be as yet unaware that they have HIV. And then as they get diagnosed, they move to a diagnosed compartment, and people in the diagnosed compartment also have a percent or proportion who are suppressed and a proportion who are unsuppressed. And then with the passage of time, people can move from acute HIV to chronic HIV. Right, so that's sort of the compartments that we use for HIV status. And when we want to look at testing, we can intervene on sort of the rates at which people move from the undiagnosed compartments to the diagnosed compartments. If we want to look at viral suppression, we can adjust that proportion of people in compartments who are virally suppressed. And if we want to look at PrEP, we can change that proportion of people who are in the uninfected compartment who are on PrEP. Right, but our model is actually more complicated than that because we take each of those states and we split them up by HIV risk factors. And then we take those states and split them up by age and race, sort of for CDC reporting categories. And so all told, that gives us 945 compartments in the model for 135 different groupings of age, race, sex, and risk factor. And the other thing I should say too, for all the cities that we modeled at the level of something called a metropolitan statistical area, right? So here's Baltimore, right? So the county that's in the EHE plan is Baltimore City County, right? But because the model assumes that all transmission events are going to be captured within our model, we didn't feel comfortable restricting it to just the county level. So metropolitan statistical areas typically include the county that has the sort of urban center and then surrounding counties, right? So for Baltimore, you've got Baltimore City, but then you've got these other 6 surrounding counties. And at the level of those 48 EHE counties plus DC, those collapse into 32 MSAs because some MSAs, like for example, there's the Miami Metropolitan Statistical Area, includes both Miami County and then the county for Fort Lauderdale, right? So those get lumped into one city or one MSA. So I don't want to belabor this point, but there's 945 compartments. There's a whole ton of model parameters that go into making this work, right? So just to give you an example, this transition here, where people become HIV infected, right? The parameters we're going to need for sexual transmission, rates of transmission per partnership. We're also going to need to know for every stratum of age, race, sex, and risk factor, what's the breakdown of their partners for other strata, right? Because we know that people tend to partner associatively, right? Or it's not totally uniform. Young people tend to partner with younger people, older people. There's patterns by race. We need then for each of those partnering strata, right? What's the proportion who are virally suppressed, or really what's the proportion who are unsuppressed who could potentially transmit? We need to capture variations over time. We then need to do that for needle sharing, right? We need to reproduce this for each of the 135 strata of age, race, sex, and risk factor, right? So it's a whole ton of model parameters that go into that. And we're drawing information on these model parameters from a whole bunch of different publicly available data sources. But what I want to highlight here is that some of these parameters, sort of like population sizes, which we get from the US Census, or birth and death rates, which we get from CDC reporting, we kind of take as gospel truth. But a lot of these other parameters have some uncertainty about them, right? If you think about the rates at which people pair up or form sexual partnerships by age, right? We draw that from some studies that are published. Those studies were not published in Baltimore, right? And so we don't say, we don't want to say, well, that parameter that was based on a study in, I forget where that one was, we'll say San Francisco. We don't want to say, well, we think that that's the gospel truth for Baltimore. And so we're going to vary some of these parameters in a calibration process. And for all these parameters, we're going to try different values and see, well, what values of those parameters give us simulated HIV epidemics that look like what we have here in Baltimore, right? So the idea is to identify the sets of parameters that give us simulations that reproduce what we see in Baltimore. So here's an example. The black circles here are total reported cases as recorded by the CDC. And this line here represents one simulation, right? So we might have a set of parameters that leads to this simulation. And we say, well, that's not a bad sort of reproduction of the epidemic that we've seen. So we like that one, right? I could draw you another line, right? Maybe a set of parameters gives us this simulation here, and that's not such a good fit. And so what our calibration process wants to do is keep simulations like this one, right? Keep the parameters that give us these simulations, but not keep simulations that look like that. And I showed you there for new diagnoses, but we're actually trying to reproduce a whole bunch of different targets, right? Diagnoses, prevalence, mortality. We also want to reproduce the proportion of people who know their status, the proportion who with HIV who are virally suppressed. We want to reproduce sort of PrEP prescriptions, the probability of receiving an HIV test, the prevalence of IV drug use, and then some historical data from early in the epidemic to kind of help us get our prevalence targets right. And so this calibration process gets a lot of fancy math that I get very excited about, but we're going to ride right past that and just say the idea is to get a whole set of simulations that kind of represents a range of different things that could lead to the epidemic that we see. And usually we use about 1,000 simulations because that kind of characterizes uncertainty well. Right, so here then I plotted you 100 because 1,000 gets really crowded simulations, right? But here again are our calibration targets, and now each line is one simulation. And so this is the actual calibrated data for Baltimore, right? So we've got a bunch of simulations, right? You know, maybe this simulation has higher transmission rates for lower age groups, and maybe this one has lower transmission for age groups, but they're sort of all capturing a range of what could be going on that's leading to the HIV epidemic that we see, right? So we're calibrating to 10 targets. So here's 4 of them, right? So we're calibrating to, this is sort of the calibration of reported cases, prevalence, viral suppression, knowledge of status. I'll point out here that this knowledge of status data, the circles, are actually Maryland data. And so based on what we know about testing at the Baltimore level, right, it estimates that Baltimore knowledge of status is probably a little higher than the state level, right? But we're actually calibrating to a finer detail than that, right? If you take that reported cases, right, you can break it down by risk factor. You can break down reported cases by race, by sex, by age, right? And the model is reproducing all these calibration targets. It's in fact even more complicated than that, because if you take that breakdown by risk factor, you can substratify within risk factor by race, by age, by all these things, right? So here is hitting the combinations or the intersections of risk factor and race. Oops. Right, and so it's hitting all these targets, and it's doing this for prevalence, it's doing this for all these targets, hitting targets at sort of multiple levels of stratification, right? And that sort of detail gives us confidence in hitting these targets that when we make projections for interventions on specific groups, that we think that those projections are valid. So that's the calibration, right? That's heavy math. And now we'll get into the good stuff and sort of projections. So if you take that calibrated set of simulations, right, we can project it out for another 10 years and say, this is what we think is going to happen by 2030. I can also show you incidents, which we don't get to observe in the real world, but at the level of the model knows when people are infected, not just when they become diagnosed, right? And if I take sort of the average of these simulations for where they are in 2020 and the average in 2030, we can calculate what the reduction would be over that time period, right? And so this is saying here, if we took no intervention, sort of other than kind of coasting on what we're doing with gains in suppression, testing, PrEP use, we think that Baltimore is going to reduce by about 37% its incidence over the coming decade, right? But there's an uncertainty range attached to that. But I could then simulate for you an intervention, right? So here's an intervention where we take young Black and Hispanic MSM and people who inject drugs, which are sort of the highest risk demographic subgroups. And we say, well, let's test them on average once a year, get 80% virally suppressed, and 10% of people from those demographic groups who are at risk for HIV, get them on PrEP, right? And you see the blue simulations start to drop a little bit, and that gives you a 47% reduction, right? So it's better than 37%, but it's not 90%, right? So you can sort of scale up the interventions, right? And say, here's that one that I just showed you. Here's another one, right? And now we're going to focus on all MSM and all people who inject drugs. And they're going to be tested here on average twice a year, 90% suppressed, 25% on PrEP, right? So these are pretty ambitious levels of interventions. And this is sort of what happens with diagnoses. You get a little bump here as that increased testing hits, and you diagnose undiagnosed people, and then you drop down. And for instance, you drop down, you get about a 79% reduction from that intervention. And so, we'll focus on Baltimore, but we did that for all the 32 cities. Here's Baltimore. This is crowded, so I'll zoom in for you a little bit, just give you the sort of top 10 by number of cases in 2018. And then there's Baltimore, right? And so just to orient you here, cells are shaded sort of with that reduction. So if you hit 90%, it gets green. Red is basically no change. And then as you get closer and closer to 90%, you get more and more yellow, right? And this is no intervention, right? So again, for all these demographic groups, no intervention, that's that 37% reduction that we talked about before. This is that first intervention that targets just the young Black and Hispanic MSM, 47% reduction, right? And this is that second intervention I showed you. It's more intensive, targets all MSM, all people who inject drugs, and a 79% reduction, right? So we explored a number of different interventions that you could take. Here is a table with several scenarios. So let's start with these three on the right. This first intervention says, what if we just do a lot of testing and nothing for suppression, nothing for PrEP use, right? We're going to test MSM and people who inject drugs twice a year, everyone else once a year. That gives you in Baltimore a 58% reduction over the coming decade. This intervention here is just PrEP, giving 25% of people from all demographic groups, all risk groups, 25% of those at risk for HIV put on PrEP. And I should say too, I forgot to say, these interventions are scaling up from 2023 to 27. So we say that they start implementation in 2023 and they reach their full levels by 2027, so a 5-year rollout. So anyways, if you do that 5-year rollout, by the time you get to 2030, you have a 56% reduction. So similar to the testing intervention, right? If you get 90% in this intervention of everybody suppressed, that gets you a 70% reduction by 2030. And so these are obviously pretty aggressive, heroic, you might even say, levels of intervention for testing, suppression, and PrEP, right? But the point is that even at these high levels, doing just one of these things is not going to get you near 90%. We also tested what we called a marginal improvement scenario, right? And rather than doing these big levels, we're going to do a little bit of everything, right? So for every demographic group, we're going to test them just 1.25 times as often per year as they otherwise would have been. For every demographic group, we're just going to get 5% more on PrEP than would otherwise be, and 10% more virally suppressed than would otherwise be. And so if you do that, but you do that for all demographic groups, you get about a 64% reduction, right? So if you do one of these things a lot, you get in this range, right? If you do everything to a smaller degree, you also get this sort of 60% reduction, right? And looking across other cities, that's in the range for what other cities do, although there's a lot of variation by city. So here are some interventions that are more intensive, doing a lot of things at once, right? And so broadly speaking, this set of 4 here is interventions that are just targeted to the young Black and Hispanic MSM risk group. This set of 4 is all MSM and all people who inject drugs. And then this set of 4 interventions is hitting everybody, right? And we're moving from sort of more, the sort of least invasive or least intensive interventions, right? Testing on average once a year, 10% on PrEP, 80% suppressed. And by the time you get over here, you're testing people twice a year, 25% on PrEP, 90% are suppressed, right? And so again, it's a lot of numbers, right? We'll focus on Baltimore, right? But the point is, if you just focus on that highest risk subgroup, you can get decent reductions, 40s, 50s. Even with intensive interventions, you're not going to approach 90, right? If you broaden out to all MSM people who inject drugs, right? Even very intensive interventions, getting you close to 80%, right? But not 90%, right? To get close to 90%, you need to be very intensive interventions, and you need to be doing it across the whole population, right? So we've also, there's a lot of stuff, obviously the table's got a lot of numbers. Because of that, we put all the projections in an interactive format on this web tool. If you want to go there, www.jgem.org, I would be delighted. If you have any feedback or say you didn't do a good job on this, you can let me know that too, because web programming is not my natural calling, shall we say. But if you go there, you can look at each of those interventions in detail, right? I'm presenting you here the total incidence reductions, but if you want to break it out by different age groups, race groups, other demographic groups, you can do that there too. And there's also a function for you to design your own intervention, right? If you want to say, well, what if we did 35% PrEP? That's not one that we tested. You can do it, you can run it, and in about 5 minutes, you'll have an answer. So conclusions as far as the EHE goals go, right? It's going to be a big lift to get to 90% reduction, right? I mean, anything even in that neighborhood takes heroic levels of PrEP, of suppression, of testing, and you need to do it across the whole population, right? You can get some pretty good reductions, not 90% if you target high-risk subgroups very intensively. Or alternatively, you can get some, decent 60s range reductions if you target everybody, but with a sort of more moderate level of improvement over where you are on all these criteria. So if it's right with everyone, I'll take a few minutes to talk about projections with COVID-19. So all this work, by the way, everything I showed you up to now does not factor in COVID-19 at all. We're doing some work now looking at what the effects of COVID-19 might be. You should take this as somewhat preliminary. It's still going through the review process, so not published at this point. But I'm excited to talk about it because I think it's kind of interesting. So when we were thinking about what might COVID-19 and the pandemic and the lockdowns do to HIV, we decided to represent it via impact on 4 parameters, right? Rates of sexual transmission, right? You can imagine lockdown, social distancing, those rates are reduced. In some preliminary studies, you got people reporting anywhere from no reduction to all the way up to 50%. So we explored that whole gamut of possibilities. Viral suppression, right? What does the COVID-19 pandemic do to viral suppression? We said it could reduce anywhere from 0 to 40%. We're going to test simulations with all ranges of those values, right? We said that it could affect HIV testing rates and then PrEP use as well, right? And we basically said these are our 4 parameters, and we're going to assume that whatever the reduction is in sexual transmission, that applies to all demographic and age groups, right? Whatever the rates are for the reduction in viral suppression, that's going to apply, whatever your reduction was going to be, it's going to apply for all age groups, right? So that's obviously a simplification, but if you do a different sort of parameter for each of these 135 groups, it starts to get to a lot of numbers and difficult to digest, right? And in terms of the time scale for how these affected, right? So let's say that for transmission, these percents were for suppression, they don't really apply to transmission, right? Let's say that you were going to have a transmission rate that's this, I think the numbers don't matter. What we say is that COVID-19 hits, and whatever that reduction is in transmission, it drops on March 1st, kind of continues at, transmission rates were going to increase slightly in this projection, so they're going to increase slightly, but at 40% of what they otherwise would have been. And then beginning of March 8th, 2021, which is when the CDC announced guidelines for what vaccinated people can do, we said it's going to start normalizing. And we said, let's let it get all the way back to normal by July 4th. Oh, that should be 2021, not 2022. July 4th, 2021, right? For suppression and also for testing and PrEP use, we let the effects linger a little longer. So again, they take effect on March 1st, 2020. But they don't begin to normalize until 6 months after transmission starts normalizing, September 8th, 2021. And then they normalize and get all the way back to normal 6 months after transmission got back to normal. So that's February 4th of 2022. Any questions? You guys can interrupt with questions anytime. So that's sort of the way that we conceived of these things, right? And so we went ahead and ran simulations. And it's a shortened time scale here. I'm just showing you from 2016 to 2025. This is reported diagnoses. This is incidence, right? And this gets crowded because the simulations are overlapping. So I'm just going to switch it to these kinds of figures, right? Where the yellow again is what would have happened if COVID never took place. And I'm a little colorblind. Maybe we'll go blue purple. This color here is what would happen, under a range of different possible simulations for what COVID-19 does to HIV transmission, right? And so you see, you kind of get this wobble here, a little bit of drop in incidence, then a little bit of rebound, diagnoses drop, and then rebound, right? But the uncertainty intervals are wide, right? And just to show you, without COVID, right, this would be on average 1,300 cases, incident cases from 2020 to 2025, right? And on average, the COVID projections are only 24 more cases, so essentially a wash, but you have a big wide confidence interval, right? Anywhere from some simulations saying you have 324 fewer cases, right, which is about 20-25% reduction of what you would have seen, to 401 more. Right? So there's a wide range of uncertainty, and that's what I want to dive into a little bit, right? It turns out that what really drives that uncertainty are the effects of sexual transmission, right? So the more you reduce transmission, the better that is for HIV, right? And on the other hand, viral suppression is the strongest determining factor, right? So the more you reduce viral suppression, the more that we think COVID-19 disrupts the continuum of care and leads to fewer people being virally suppressed, the more HIV you're going to have over time, right? So I've split out those projections here. These on the top are just the projections with a big reduction in sexual transmission and a relatively small reduction in viral suppression, right? And so for these people, for these simulations, I should say, incidence does better, right? We have fewer cases over this time. You see a drop in diagnosis and things get back to normal. This bottom set of simulations here is just the simulations that have a relatively low effect on sexual transmission, but a big effect on viral suppression, right? Viral suppression is reduced by 25% or more, right? And what you see here for incidence is you get more, right? But what is interesting and maybe concerning is that even in these scenarios where you're getting more cases, you're seeing an initial drop in diagnosis, right? Which is probably due to fewer people being tested as the pandemic also disrupts testing patterns, right? And the thing that I think is interesting / concerning here, right, is if you look at these two, you're not going to tell, right, in terms of reported diagnoses, these look similar for the first few years, right? So in other words, we're probably going to see a drop 2020, 2021, maybe even 2022, no matter what's happening, and eventually a rebound, right? But this is not, for the next coming years, reported diagnoses are not going to reflect underlying incidence trends well, right? In particular, in these scenarios where you had more transmission, right, cases start to bump, and it looks like they're spiking here in 2022, but they're actually already declining. True incidence is actually declining in that point. So the take home here is that we think, for the next few years, your standard HIV reporting is probably going to be a little wacky, right? It's not going to be a good sense of what's going on underneath the surface. One other thing I want to show you, and so this is just a heat map of the same sorts of results here at a more finely stratified level, right? So this is what you might be doing for sexual transmission. As you move left to right, you get a bigger reduction in sexual transmission. And this is what you're doing to viral suppression. So as you move top to bottom, you get a bigger effect on viral suppression, right? And then the coding is relatively how many more or fewer cases. The shading is how many more or fewer cases of HIV do you get over this 5-year time frame relative to what you would have gotten without COVID, right? So again, this is if you have a big reduction in suppression, not a lot of change in sexual transmission, you're going to get a lot more cases. And if it's the vice versa, right, a big reduction in sexual transmission, but not as big a reduction in suppression, then you're going to get fewer cases, right? So you can think in your mind, if you have intuitions on sort of where these things are, where you think we might be on the heat map. I will say, right, looking at other data, right, we've thought a lot about what other data could you use to get at these questions, right? And, for sexual transmission, you could look at rates of other STDs that are symptomatic, right? So thinking gonorrhea, primary, secondary syphilis, right? How much of those change, right? And at least preliminary stuff is those probably haven't changed a whole lot, which maybe means, sexual transmission did not decrease a whole lot, or at least not for very long, right? For viral suppression, it's really hard to say. There's been, in terms of the proportion of viral loads that are undetectable, there hasn't been a big change, but there's been a huge drop in the number of viral loads that were done, right? So are those people who are getting viral loads, is it they're just staying home, but they're otherwise just as suppressed as they would have been? Or is that reflecting, people falling out of care and not being suppressed, right? It's hard to know. And that's sort of the point of this work, is it's still hard to know really what the effects of COVID are going to be. One last thing I'll show you, right? This is that same bad scenario here, right? Where sexual transmission doesn't change a whole lot, but viral suppression does reduce a lot, right? This is those same parameters, but saying, well, what if we got viral suppression back up to normal this past summer, right? And the effect is blunted, right? You get less of a rise in cases, right? So in terms of the things that we can control here, right? We may not be able to control, how much people's sexual transmission behaviors go, right? But as a health system, the one thing we maybe could intervene on is making sure people get back plugged into care, reestablishing the continuum as soon as possible, right? And that's sort of the one thing you can do to sort of blunt the effects of COVID if they're going to be bad. So, conclusions there, right? One is that it's really hard to say so far really what COVID is going to do for HIV transmission. It's going to depend primarily on the degree to which continuum of care gets disrupted and sexual transmission gets changed, right? And the other take-home point is that traditional HIV reporting around reported diagnoses is not going to be a good barometer of what's really going on at the transmission level for the next few years. So limitations for our approach here in general, right? It's a compartmental model. And so we make the assumption that within a subgroup of age, sex, race, risk factor, people behave on average the same. There's obviously people behave differently. There's a lot of heterogeneity, and we're skating over all that, right? So we're not going to be able to represent detailed needle sharing networks or sexual networks. For this work, the continuum of care is also collapsed. We haven't broken out specifically people being engaged, people being on ART or adherent. We just say, are they suppressed or not? And then, as far as COVID-19, so far it's a relatively simplified view of the effects, right? So future directions here, we're working now on expanding out the HIV care continuum so you can look at specific interventions on retention or adherence, factoring in sort of some of those other epidemiological data points to get a better handle on COVID-19, and then working on costing and eventually those state level models. With that, I'd like to say thanks to all the collaborators and to the funders who made this work possible. My email's there if you have any questions, and I'm happy to answer questions now. Thank you.
Thanks so much for that. If anyone has any questions, please feel free to unmute or to place in the chat. I'll start with one question, which is in terms of interventions at the local level to reduce incident infections. Like what you've presented is this sort of a high level view of what that looks like. For the average clinician who's practicing in our clinic, like what is the big takeaway you would say from your model about what needs to be done at the local level at Baltimore to reduce incident cases?
Yeah, I mean, right. So, I mean, again, for Baltimore, probably the heaviest, again, it depends sort of on the number you say, right? But getting people virally suppressed, big potential impact, right? That's probably, for the interventions, the largest thing, right? So for HIV providers, getting people suppressed, right? And so, I mean, this is not telling you something that you don't know, right? You can also then think about in terms of preventive interventions, right? So for primary care clinic, which is where I have my clinic, right? Making sure people are tested regularly. And then, in terms of areas for big improvement, there's not a whole lot at the population level of PrEP use, right? That's a big place where you can really expand, right? And getting high risk people on PrEP, right? But it is, sort of the takeaway too is, I mean, PrEP is always a good proposition for sort of the individual patient level, right? But at the population level, you're going to need a lot of PrEP to bend the curve, right? So you need to do this sort of not just one-off, but systematically, right? And so again, not my area of expertise, but not, maybe you can chime in here too, right? But you can think about me, how good am I at making sure that everybody in my primary care clinic who's potentially eligible gets PrEP, right? Maybe it's going to take something on a more systematic level. If you really want to hit 25% coverage, right? It's probably going to be more than just, okay, well, doctor sitting in your primary care clinic, make sure you get PrEP to people.
Yeah, I mean, I think this is less for the individual level clinician, and this is really more sort of thinking at a public health level of what is it going to take. I mean, that's sort of what the article is even called, right? And so it's asking the question, we've set these ambitious goals, but part of what Todd's model does really elegantly is tries to quantify how much benefit are you really going to get for the different strategies we currently have. We say things like, yeah, we want to get people on PrEP, and that sounds great, but part of what we were able to show, and what Todd was really able to show, is the levels of PrEP, for example, that it's really going to take if you really want to get to 90% reductions in incidence, and that the current tools that we have in our armamentarium, they would require really high levels of scale up to be able to achieve these targets. So there's a little bit of a mismatch. Maybe it's a little bit of a call to needing newer interventions and targets. And one of those, for example, may in fact be on the horizon, which is long-acting injectable PrEP, right? So we may in fact finally be able to, perhaps by having a bigger menu of interventions, push beyond the 10, 15% PrEP coverage or effective PrEP coverage that we're at today. But the next steps are really to try to also tease out where does adherence and retention and care fall, because part of what this work and some of the other work that we had done previously also shows is that in order to actually bend the curve of the HIV epidemic is going to require really high rates of retention and care on an annual basis. So again, that's not anything everybody here doesn't already know, but this starts to put numbers towards, trying to say, what are our actual targets, and recognizing that even small drop-offs in the percent suppressed ultimately ends up leading to sizable increases in incidence. And the converse is that to actually achieve meaningful reductions in HIV incidence, it's going to require really high rates of all of these things. And so maybe that's a little bit of a pessimistic take, but I think it starts to get at the realities of what is going to be needed. So it's one thing to set these targets and keep them ambitious, which is great, but now this is trying to start to create a roadmap for what will it sort of what are the proximal targets that you'll need in order to actually achieve those EHE goals.
Yeah, that's helpful. I mean, because I do feel like we keep hearing, but we keep talking about, PrEP uptake being the problem. But I think as you're saying, what you all are showing is that alone is not necessarily the problem. And we need to do a lot of other things. And as you're saying, perhaps newer interventions that we haven't even imagined yet, because
yeah, I mean, like you can start to think about like how the shape of the epidemic will change, both with long-acting injectable PrEP, but also perhaps with long-acting injectable ART, right? So where it probably already has changed a little bit as we have more forgiving regimens in terms of adherence. So you don't maybe see the same breakthrough in virologic suppression that was perhaps experienced previously. So I think all of these are incremental, but I think even beyond we get people onto ART, and Todd didn't really show it, but they already have some other work where they've expanded out the care continuum and are going to be looking at the levels of retention and care that are a sort of engagement that are also going to be needed. And I think that starts to get to, well, what are the ancillary services, wraparound services that we are really going to need to ensure that people don't actually fall out of care, because declines in percent suppressed ends up translating to, I mean, I think we all know this, but more transmission, but it's a sizable amount when you think about it at a population level.
Yeah. Any other questions or comments from the group? And Manag, was this, I know that Manag, at least you have some support from CDC to do modeling work to help them with their planning. Is this part of that effort, the study here?
No, so the original model upon which this is sort of loosely based, it was supported by the CDC. It's sort of through a prevention grant. But this was a complete reconstruction and recreation from scratch that Todd has done in a much more sophisticated way. The initial model was a national level look. So we had like 10 compartments where Todd has hundreds. It's risk stratified, age stratified, race stratified and age stratified, and has every MSA. So and it would apply a whole new sort of approach. And this sort of, I mean, Todd can speak to what supported him, but this was not directly funded by the CDC, though, we've reached out to a number of different groups to share the results and have gotten good feedback. It was published in the annals, and some of this, just as other background, this came to us, some of the ideas of this, about 3 years ago, the state of California reached out to us, having seen the national level model, and said, we've developed this ending the epidemic roadmap and strategy, but we want to put numbers to this, because it's one thing to say, we want to get to 90% reduction in incidence, but what you really need for public health implementers is to be able to evaluate their own care continua, right? And so to say, so for public health purposes, it's saying, what is the percent retained in care that we need that will eventually translate to these epidemiologic goals? And so they had reached out to us to do some of this work, and we kind of put it on the shelf because we didn't have dedicated funding. But functionally, Todd ended up doing not just California, but doing everybody. And if you haven't played with the little interactive tool, it's pretty cool. I encourage you to go to it because it really is sort of a new and innovative approach to disseminating results to try to individualize public health or should not individualize, but essentially tailor public health to the local settings.
I mean, I think it'll be especially interesting as we see, I think different institutions are going to implement PrEP long-acting PrEP in different ways. And I know this is something that Yuka and Matthew were talking a lot about here in terms of how we're going to do it. So it'll be interesting to see, if you apply that model in different places who are doing different things with accessibility to long-acting PrEP, what it would look like in the long term. Yeah. Any other questions from the group? If not, I know Joyce has an update on substance use management options in the Bartlett Clinic, so I'm going to let her take over. Todd, Monang, thank you so much again for presenting this data. It is really fascinating to see the big picture public health view of things, especially for those of us who are sort of in the weeds in the clinic. So I really appreciate it and appreciate the work you're doing. Todd, if you could put the tool link in the chat, that would be great. People could share it too.
Thank you.
Thanks.
Yeah, thank you, Todd and Monang, for the work and the presentation. Really helpful for the local efforts here and the things we're doing in the clinic. So I asked Natasha if we could just make an announcement as a follow-up to an email I sent about the options for treatment of substance use disorder in Bartlett. You all know that we've for a long time have been able to offer Suboxone for people with opioid use disorder in our clinic through the work of Phyllis Hubbard and Greg Lucas, Tanita Woodson, and Patty Bardich. And that started, I think, over a decade ago through a SPINS grant and has been very successful. And Dr. Shon Falade got a grant that led to the Restore program, where we could offer treatment for substance use disorder, not just for people living with HIV, but for people who are HIV negative as well. And that has been quite successful. That program run by Dr. Falade and Tracy Agee, the grant funding for that has ended. And we also have faced some budget cuts from our Ryan White program, which has supported the original opioid use disorder program at Bartlett. So we are, well, actually really the teams, so the Restore team and the original OUD team at Bartlett are working together to integrate the programs. So I did send an email about the work of integration, and we will maintain a core team of substance abuse counselor, peer recovery specialist, nurse practitioner, and physician support to continue to offer treatment for substance use disorder. The treatment for now is going to be in the clinic will be limited to treating opioid use disorder and alcohol use disorder. The team will be able to take referrals for linkage. So that's a really important piece that Restore augmented, was really being a source to link people to treatment, not just within the clinic, but outside of the clinic. So that will continue. And the teams are integrating the process of doing the in-clinic treatment of opioid use disorder and alcohol use disorder. We've also been talking a lot about intensity of treatment. So, there's people who are initiating treatment and then achieving recovery, and then people who are in stable recovery. So one of the things that we're working towards is people who are in stable recovery to transition their prescriptions for medication-assisted therapy to their primary care providers. They would still receive support from the substance use disorder team for counseling in groups and things like that. And there would be guidance to primary care providers. But for people who are really stable in recovery, and this is something that really should be integrated into primary care, is the maintenance of prescriptions for the medication assisted therapy. So I just wanted to, provide a follow-up to the email. And if you all have any questions, there's definitely more to come from our team. But if you have questions in the meantime or suggestions, please reach out to us. And I don't know if there's any time for questions now, but I'm happy to answer them. And I think Shone is on the call as well.
Thanks, Jess. I'll just also note for those of you who are seeking a refresher, Shone is actually giving a talk next week for this conference on the management of opiate use disorder and alcohol use disorder in folks, and talking a little bit more about her work. So that'll be a great update for all of us.
Thanks, Natasha.
Anyone have any questions for Joyce or Yuka or Shone? Quiet today. I think the rain is making everyone depressed and no one wants to talk. Joe's nodding vigorously.